emergency scene in PHO. We already did. Dr. Ashwini will brief the disease common encountered and the practical aspects. And then we'll have an interactive quiz session for all the nurses here. So over to you, Dr. Ashwini. Dr. Ashwini is a assistant professor in the Chandra Hospital, Chennai. So she'll be talking about the oncological emergency.
So good evening everyone to all those who have joined today. So today's session topic will be oncological emergencies in children. So let's have an interactive session, and please feel free to share your thoughts and questions as we go along the session. So coming to what is oncological emergency, it is a clinical condition resulting from a metabolic, neurological, cardiovascular, hematological or infectious changes caused by the cancer or its treatment that requires an immediate intervention to prevent the loss of life or quality of life. It can occur as an initial manifestation of the cancer or as a side effect of the therapy or at the time of progression, or it can also occur during the recurrence of the disease. So there are various types of oncological emergencies, like metabolic oncological emergency, among which tumor lysis syndrome is more commonly seen in children. Among the neurological emergencies, spinal cord compression is more commonly seen in children. Among the cardiovascular emergencies, superior vena cava or superior mediastinal syndrome is seen in children. In hematological emergency, hyperleukocytosis is commonly seen in children, and among the infectious complications, febrile neutropenia is commonly seen in children. So let's discuss scenario based. We have a child who is a diagnosed case of ALL on delayed intensification phase, came with a temperature of 100.5, his vitals are stable. And there is no focus of infection. We have another child with Wilms tumor who is on chemotherapy, has a temperature of 101. He is playful and the focus seems to be the upper respiratory tract infection. There is another child who is a case of relapse ALL on reinduction, has a temperature of 99.8 for last 2 hours. Who is active and no focus of infection is identified. Another case of AML on consolidation, high dose cytarabine therapy, who has severe throat pain, no fever, and he has a grade 1 mucositis. So are all the temperature increases indicative of febrile neutropenia? No. So what is the definition for febrile neutropenia? ITSA guideline says a single oral temperature of more than 101 degree Fahrenheit or a temperature of 100.4 degree Fahrenheit for at least an hour. Neutropenia, either an absolute neutrophil count of less than 500 or less than 1000 with a predicted decrease below 500 in next 48 hours. ESMO guideline says an oral temperature of same 38.3 or 2 readings more than 38 for 2 hours, with along with the ANC of less than 500 or expected to fall below 500. Temperatures taken via alternate routes, including rectal, should be discouraged as the children are neutropenic and it will introduce the risk of infection. So, child has come with fever and child is neutropenic. How to approach the child? Take a quick history and do a short physical examination, which should be concentrated on look for the focus of infection in the ear, oral cavity, pharynx, lung signs, and any venous access child has a chemoport or PICC line site, thrombophlebitis or infection, bone marrow aspiration site, you should look for this infection. Or a child has any signs of typhlitis like vomiting, abdominal pain, constipation, you also should look in the perianal region, which can be the hidden source of infection, and also look at the males. So you should have a special attention to clues suggesting etiology or focus of infection. Also try to identify any features that may help to risk stratify the patient. So you have examined the child. So what will you do next? Investigation by CBSD is the most important, and blood culture from the peripheral and the central line cultures is the second most important. Chest X-ray if any lung signs are present. The other investigations like electrolytes, creatinine are not an emergency, but still if you are sending, it is better to send these investigations also. So management, febrile neutropenia is the most important oncological emergency because it has a high morbidity and high mortality rate. So through thorough evaluation and prompt antibiotic administration reduces this mortality and morbidity. So in febrile neutropenia, you should always do, then think. Think and do is better avoided. So, febrile neutropenia is considered as a medical emergency. Initial impression should be done in the first minute. Primary assessment and investigation should be done in the 5 minutes. And the first dose of antibiotics to the child should be given within 10 to 15 minutes. If not, it should be at least given within the 1 hour from the time of the child's presentation. So this 1 hour is considered as the golden hour for the febrile neutropenic children because they have done a study and proven that the antibiotics administered within the first hour of the presentation has decreased the febrile neutropenia associated morbidity and mortality in children. And you continue with the other supportive treatment and call for help. What are the antibiotic of choice in these children? Um, as we have already seen, the prompt initiation of antibiotic therapy has reduced the mortality rate significantly. Broad spectrum antibiotic with an anti-pseudomonal cover like a piperacillin, tazobactam, and amikacin should be started. However, the choice of antibiotic depends on the type of bloodstream infection and antibiotic susceptibility pattern at the local institutions. Coming to the next scenario, a 10-year-old boy with fever and abdominal pain for last 10 days. On examination, he has a right iliac fossa mass with the tenderness. USG reveals a right cecal wall mass with lymphadenopathy and hypoechoic lesions in the liver. Then the examinations give you the result of child has an decreased urine output. There are multiple electrolyte abnormalities, and the final diagnosis comes out to be Burkitt's lymphoma. So, what is this scenario? It is a tumor lysis syndrome. So, tumor lysis syndrome consists of metabolic abnormalities which result from the death of the tumor cells and release of their contents into the circulation. Although tumor lysis syndrome can occur prior to any cytotoxic therapy, its manifestation usually appears from 12 to 72 hours from the initiation of the therapy. So in tumor lysis syndrome, we can see hyperkalemia, which is a high potassium levels in blood, hyperuricemia, which is excess uric acid in the blood, hyperphosphatemia, which is high blood phosphate levels, and hypocalcemia, which is a low calcium level in the blood. There is a criteria for the diagnosis of tumor lysis syndrome, which is divided into laboratory TLS and the clinical TLS. In the laboratory TLS, at least 2 or more of the following should be present, like uric acid more than 8, phosphorus more than 4.5 in adults and 6.5 in children, potassium more than 6, and calcium less than 7. In the clinical TLS, along with the presence of laboratory TLS, any one of the clinical TLS should be present, like an acute kidney injury or cardiac arrhythmias leading to death or seizures. So, should we be worried about the TLS in all pediatric cancer children? No, even though the TLS can present in any children with cancer, these children like NHL, in among which the Burkitt's lymphoma, acute leukemia with total count of more than 1 lakh, and children with bulky disease, they are at the highest risk for tumor lysis syndrome. So we should be monitoring the tumor lysis syndrome in these patients specifically. So how do you manage these children? Intense hydration is the key. In the hydration, potassium should be avoided because already the tumor lysis syndrome, you have a high potassium level in the blood. So no potassium containing fluid should be given. Cardiac monitoring should be done. Strict input and output should be done with a urine output target of more than 2 ml per kg per hour. And you should manage electrolyte imbalances accordingly. The pharmacological interventions like allopurinol should be started at 10 mg per kg per day in divided doses. Rasburicase in high risk cases or already the child in TLS. Phosphate and potassium binders. Dialysis if the child is refractory to all the above mentioned medical management. So what are the points to remember in the management of TLS? No addition of potassium in the fluids. Inform the critical values as early as possible for the early intervention to prevent the end organ damage. Coming to the next scenario, we have a 5-year-old boy with a history of fever and fatigability for last 1 month, which is intermittent in nature. On examination, child has generalized edema, petechial spots are there, and splenomegaly is present. On investigation, the hemoglobin is found to be 4.5 and the total count is 2.2 lakhs with the platelet count of 27,000. The diagnosis comes to be a TALL with hyperleukocytosis. So in this scenario, the striking point is the total count. The normal count is 11,000 and this child has a count of 2.2 lakhs. So what is hyperleukocytosis and why it is so important? Peripheral leukocyte count exceeding 1 lakh is called hyperleukocytosis. It leads to hyperviscosity, multiple metabolic dearrangements, and the organ involvement, among which the major affected organs are CNS, in which it can cause hemorrhage or thrombosis. It could also cause a pulmonary leukostasis, which leads to desaturations and respiratory failure. It also affects the kidney, leading to renal injury. So how do you manage this hyperleukocytosis? Again, in intense hydration with a target of 3 liter per meter square per day. And as already mentioned, give allopurinol, prophylactic raspuricase, maintain an urine output of more than 2 ml per kg per hour. And normally we target a platelet count of 10 to 20,000, but 10 patients with hyperleukocytosis try maintaining a platelet count of more than 50,000 and monitor the TLS parameters 4 to 6 hourly because these hyperleukocytosis patients are at high risk for tumor lysis syndrome. So, our next scenario, we have a 5-year-old boy who has a neck swelling for 1 month. His vitals were stable at presentation. So, after the initial investigation, the child was planned for excision biopsy. So for excision biopsy, child was given a IV sedation. Suddenly, the saturation from 100% in room air dropped to 20%, and the child went into gasping. So, what caused the child to experience the respiratory failure? Any child with a huge neck mass get an X-ray done before any procedure or IV sedation. To look for, so what we look for in the chest X-ray is the mediastinal mass. So this child had a mediastinal mass. So as soon as the sedation was given, the child went into the respiratory failure. So this is a lateral X-ray view which shows the anterior mediastinum, middle mediastinum, and posterior mediastinum. In anterior mediastinum, the most commonly seen mass are T cell leukemia, lymphoma, Hodgkin's lymphoma, germ cell tumor, thymoma, thymic carcinoma, and LCH. And in posterior mediastinum, the most commonly seen tumors are neuroblastoma and LCH. So, what is this child initially had? It can be either superior vena cava syndrome or superior mediastinal syndrome. Superior vena cava syndrome consists of signs and symptoms of SVC obstruction due to compression or thrombosis. Superior mediastinal syndrome, it consists of superior vena cava syndrome along with the tracheal compression due to large mediastinal mass compressing the SVC. So examine completely, look for a dilated veins and hear the stridor. In SVC syndrome, the children can have swelling, plethora, and cyanosis of the face, neck, and upper extremities, suffusion of the conjunctiva, engorgement of the veins of the upper part of the body, altered mental status, lethargy, confusion, headache, irritability, blurred vision, or syncope. In case of superior mediastinal syndrome, the respiratory symptoms will be predominantly cough, hoarseness, dyspnea, orthopnea, wheezing, and stridor. Supine position worsen symptoms, dysphagia, chest pain, altered mental status, and syncope. So how will you provide the best possible management for these kind of children, avoiding the biopsy or sedation? So you should approach with the least invasive diagnostic approach, like the mediastinal mass with the pleural effusion. You should try doing a pleural or pericardial tap, or you can do a bone marrow aspiration and biopsy under local anesthesia. So try to avoid a procedural sedation or GA in these children. So, what are all the do's in a child with superior mediastinal syndrome or superior vena cava syndrome? Vascular access should be placed in the lower limb. Adequate hydration and a raspuricase should be given for the management of tumor lysis. As we already mentioned, in case of bulky disease, there is a risk for tumor lysis syndrome. And child should be kept in a propped up position and oxygen supplementation should be given. So in these children, steroids are life-saving. However, if you give steroids, it might mask the diagnosis. So when should we give steroids? Even pre-diagnosis. If the child has an airway compression of more than 50%, or if the child is sick, if he can't lie down supine, child is restless, child is having a stridor, a child needs oxygen supplement. So do the diagnostic procedure if possible prior to the use of steroids, or try to do within the 2 days of initiating steroids. And next scenario, we have a 6-year-old boy who came with complaints of fever and back pain since last 1 month, and parents noticed a loss of sensation and weakness in bilateral lower limb since 1 day. So this image depicts a spinal tumor which is extending into the spinal canal, causing the spinal cord compression. So spinal cord compression is a true medical emergency. It is seen in 2.7 to 5% of the children with cancer. So it should be suspected in any child with a known case of malignancy, and the child is complaining of persistent, severe, and progressive back pain. A differential diagnosis for spinal cord compression or lymphomas, leukemias, Ewing sarcoma, and neuroblastoma. MRI is the preferred investigation of choice for these diagnoses. And management involves a multidisciplinary approach like initiation of steroids at the earliest, undergoing decompression for following the laminectomy, and initiation of chemotherapy. Next scenario, we have an 8-year-old boy, case of BALL on delayed intensification phase. He was admitted for the chemotherapy. Child was administered with injection vincristine and doxorubicin as per orders. Few hours later, parents came complaining of pain and swelling at the injection site. So this was the picture when the parents came and complained. What is this picture showing is an extravasation injury caused by the extravasation of the chemotherapy which we have administered. So with the vesicant and irritant drugs, we should be very careful while administering, because these vesicant drugs can cause damage to skin, subcutaneous tissues, nerves, hair follicle, and sebaceous glands in the area, and it can also cause a deep necrotic ulcer. So, what is the best possible way to prevent, to avoid this extravasation injury? Is prevention, not the treatment. How can you prevent? By ensuring the patency of the vascular access device, carefully monitoring of the infusions during the administration, and use a clear tape or dressing to allow for the visual inspection of the infusion site. So it has happened already. How will you manage? Immediately stop the IV push or infusion if the patient complains of pain or any burning sensation. Disconnect the IV tubing from the IV device, but do not remove the IV device or the port needle. Leave the catheter or the needle in place initially to attempt to aspirate the fluid or drug from the extravasated area. Remove the peripheral IV device or the port needle. Assess the site of extravasation and symptoms of the patient. Elevate the affected limb to minimize the swelling and encourage resorption of the drug via the lymphatic system. Apply either a dry, warm, or cold compress. Generally, for all extravasation, we give cold compresses, except for few drugs like vinca alkaloids, etoposide, oxaliplatin, vasopressors, as the cold compression worsens the tissue ulceration caused by these drugs. So, in case of administration of vincristine or etoposide, oxaliplatin extravasation, warm compressions are preferred to increase the blood flow and to also enhance the drug removal. So it should be compressed for about 20 to 60 minutes, 3 to 4 times daily for first 24 to 72 hours after extravasation. Another option for the vincristine extravasation is the local infiltration of the hyaluronidase. So just a few words. We have a child case of ALL on chemotherapy. The child is presenting with the seizures. It could be due to either disease related like CNS disease, IC bleed, or treatment related like PRES due to the steroid use, SAIDH due to hyponatremia or hypocalcemia, central venous thrombosis due to L-asparginase use, or infection related brain abscess. So, how will you approach this child? Check BP. It will indicate the presence of PRES and do an followed by an MRI imaging of the brain. Check for the electrolytes and VBG imaging, as I already told, MRI brain, and you should start the antiepileptics. So this is the end of my discussion. So oncological emergencies, it should be managed by teamwork, shared care, which leads to a better patient safety. Early detection and early intervention helps in the reduction of the emergent care. So thank you for listening to my session. It will be followed by a quiz session, which will be taken over by Dr. Dharani.
Thanks, Ashwini, for a comprehensive talk. Any questions or comments for the talk? Anyone has any questions, comments? If you have any, you can post on the chat box. So we'll move to the next session. This is a quiz, so you really need to interact. If you want, you can unmute and answer. Manisha, can they unmute and answer?
Yes, yes.
Okay, they can unmute themselves and answer, or they can put the answers in chat box. So it will be a discussion. So it will be good if one of you discuss so that all others can be clear. Manisha, can you share my PPT, please? I have kept few basic questions that everyone is supposed to know, and few clinical scenario type of questions that what you do, you have to discuss. So whoever is interested can unmute and start talking.
Are you able to see my screen?
I'm able to see only a black screen. Not sure whether everyone else is seeing.
One second. There.
Not it.
Uh, Dr. Dharani, I am not able to share my screen.
Good. Okay.
Actually, my screen got frozen. So,
Okay. I'll try sharing. Are you able to see?
yes.
Yeah. Okay. So the only problem is I won't be able to see who is replying on the chat box. So if there are any chat box things, you can please let me know. So is everyone able to see the screen now? Manisha, is the screen visible?
Yes, your screen is visible.
Okay. So I request all of you to unmute and just discuss the answers. So this is a very simple question to begin with. So when the patient is on steroids, so most of the leukemia patient, lymphoma patient is on steroids. So what is the biochemical parameter you would like to monitor? I think the choice of quiz is to have an interactive session. Anyone wants to unmute and answer? Are there any answers on the chat box, Manisha?
There is one answer, which is blood sugar.
Very good. Okay. So very good, whoever has answered. So is what is the other vital parameter that we need to be very particular when the patient is on a high dose steroid? Can someone answer that?
Hyperglycemic. There is one answer.
Any other vital signs? So, what is PRESS? Anyone can answer? Unmute and answer. PRESS, posterior reversible encephalopathy syndrome. I think it will be difficult for me to see the names actually
Can I try
because I'm
again,
sharing
once
this.
again to
Yeah,
share this?
please. Yeah. Thanks.
Can you stop sharing?
Yes,
Then
yes. Yeah, stop sharing. Panisha, your screen has an issue.
I think my screen has some issues. I'm not able to share my screen. I don't know why.
That's fine. I'll share again. We'll have a discussion.
Yeah.
So, uh, if there is any answers in the thing, you can let me know.
Sure.
Yeah. So, posterior reversible encephalopathy syndrome is related to a sudden onset hypertension, which happens with children on high dose steroids. Suddenly, they have a vacant stare. They just keep looking at one place. They are shouting. And when you check the BP, if it is very high, we need to be very careful because they can suddenly throw seizures when they are on high dose steroids because of acute hypertension. And this can change the course of the illness itself. So, whenever they are on steroids, we should monitor the BP and blood sugar very carefully. So, are you able to see the infusion that is connected? There is a bottle with some infusion. So, what is that? The nurses who will be in ICU and
There is one answer
drug which is
for
getting.
press. So, Dr. Dharani, there is one answer.
Yeah.
So, they are saying option B.
No, this is a second question is the, I'm sorry, there is a, can you see this infusion set which is hung? That question is different. So that is a third question that you are seeing. What I'm asking is this is a separate question and this is an infusion which is connected to a patient. So what infusion is this in hematology? What is the importance? Anyone just guess because it's a red color infusion. So what could it be? No answers?
So, people are
Okay,
saying iron supplement, iron injection.
great. That's great. So it's a IV iron. So what is the precaution that we need to take with this IV iron is that it can cause allergic reactions significantly
and we need to really pre-medicate them and preferably give it in the ICU setting, especially in children. And if they are non-allergic for 3-4 infusions, then we can give them, but still needs monitoring. So this is an IV iron infusion. And it is always given over 1 hour infusion slowly because it can cause significant thrombophlebitis. Okay, very good. So this is the third question now. So now I think someone has already answered the answer B. So bone marrow examination can be done from usually posterior superior iliac spine. If posterior superior iliac spine, here, suppose the patient is very obese, we are not able to reach the posterior superior iliac spine, or there are some skin issues in that area, we are not able to prick. So what is the other side that we can try? Two other sides, we can try to aspirate the bone marrow. Any guesses? So 99% we do in the posterior superior iliac spine only. In very small babies where the posterior superior iliac spine is not well formed, we can do from the upper 1/3 of the tibia. So where you put your intraosseous needle for IV access, that is one place where we can use. But in adults, we can also use from anterior superior iliac spine or sternum. But we have to be very careful because if we go very deep, it can puncture the mediastinal blood vessels, heart. So we have to be very careful. So sternum is the next place where we can do the bone marrow. So anterior superior iliac spine we can try, sternum we can try. In very small babies, upper 1/3 of tibia can be used for aspirating the bone marrow. Okay. So we'll come to this question. Which chemotherapy medication can never be given intrathecally? I know most of you know the answer. Just come on.
So we have an answer A and other one is D.
Good. So D is the right answer. We have asked it can never be given intrathecally. That is the question. So methotrexate, cytarabine, hydrocot. These are the three drugs which are approved for use in intrathecal chemotherapy. Vincristine is something which should not even be taken into the place where LT is being done. Okay. So I think those who have answered A probably misread the question. So can never be given intrathecally is vincristine. So there are policies. What happens when we give vincristine intrathecally by mistake? Anyone can attempt. So the child will die immediately. There is no question only. The child will die immediately on table. As we finish the injection, child will be dying because it will cause significant necrotizing encephalitis. So that is why vincristine is always colorless. Methotrexate intrathecal is always yellow colored. So this color coding is very, very important. Even if we have a lot of problems, we are giving intrathecal chemotherapy. Methotrexate, when we are injecting, it should always be yellow color. That is very, very important. Okay. So this really needs discussion. You can't type the answer. So a 5-year-old girl with aplastic anemia undergoing bone marrow transplant. Currently, stem cells are infused day plus 4 today. Child has 101-degree fever with heart rate of 199. 5-year-old child, 199 heart rate, 101 fever. What do we do next? Can type as well, but try to talk. Someone, whoever is there in the room.
I request all the participants to unmute yourself. If you are not able to unmute, just let me know. So Anish is answering blood culture antibiotics, and someone is answering that send the culture and start the antibiotics as per order.
Very good. Immediately. Then, so what is the significance of this scenario? Antibiotics, yes, definitely we should start. Culture immediately, antibiotic immediately. That is definitely mandatory. But is antibiotic alone enough here? So this scenario is something called as disproportionate tachycardia. Okay. So For a 5-year-old child, you can have a maximum heart rate up to 120. And with every 1 degree temperature increase, we can have 10 beats increase. So for 101, you can expect somewhere around 140, 150, we can accept it as normal. But if it is beyond that, it means that it is not only because of fever, it means that the sepsis is very uncontrolled and the child is already in septic shock. So this proportionate tachycardia is a sign of septic shock. So this warrants immediate antibiotics, yes, right? But also a fluid bolus immediately, and we need to shift and monitor the BP, urine output, everything significantly. So this point of time, even if you check the BP, sometimes it may be normal to begin with. But if you don't act at this point of time, so the child will crash. And once they are already in hypotension, we can't do anything to get them back because the counts are zero. We have to really fight hard. So the disproportionate tachycardia is the early warning sign of septic shock. So when you see that, call for help, give a med call, start fluid bolus, start antibiotics, shift them to PICU for monitoring. Okay, this is very important. So this is a similar question, so I will not repeat this. A 5-year-old girl, ATG as a part of conditioning you're giving, anti-thymocyte globulin, and the child develops fever. So what should we inform immediately? So whenever there is a patient undergoing bone marrow transplant or any intensive chemotherapy, when you have fever, the immediate next vital just to be seen is heart rate. So heart rate will give you a clue. Heart rate is 120, 130. Yes, it's not very emergency or child is relatively stable. You can see within another 15 minutes. But heart rate is 199. We have to jump and see immediately. That is the most important point that you should know. Okay. So now a 4-year-old child with ALL therapy. He's planned for donorobicin. So what is the test we ask for usually before giving the donorobicin? Any answers? It's very easy. You must all be knowing.
So A and
A,
someone answered D. Echo.
good. So echocardiogram is the right answer. So donorobicin, doxorubicin, all these are called anthracyclines. Anthracyclines can cause cardiotoxicity significantly. So anthracyclines, cardiotoxicity. This we should remember. So danorubicin, doxorubicin, idarubicin. All these rubicin medicines are anthracyclines, and we need to monitor echo before starting chemotherapy and periodically during chemotherapy. Okay. So the next question, this has been covered by Ashwini. So child with BALL, when IV vincristine given, bulge in the IV line site. So what do you do now? I think I'll discuss this because she already discussed. So first thing is do not panic and remove line immediately. So aspirate whatever you could aspirate and then remove the IV line. Vincristine always has warm compressed. V and W, they are alphabets together. So V, W, vincristine, warm. Doxorubicin, donorubicin, cold. Okay, C and D are together in alphabet. So cold is donorubicin, cold compress for donorubicin, warm compress for vincristine. Okay. Hyaluronidase is a specific antidote which is given for vincristine extravasation. So what is this instrument? It's a very common instrument that all the onco-nurses use every day.
So there are some answers. Port, chemoport, subsite needle. Mostly the
Okay.
chemoport. There are
Okay.
answers.
So it's
Yeah.
basically a chemoport access needle. It's called as Huber needle. Okay, it's like a butterfly wing with the pointed needle. So that is called as Huber needle that is used to access the chemo port when needed. So it's a Huber needle. Okay. So what is this? The next instrument. So I'll give you a clue. So this is an infusion pump connected to some infusion which is already filled in, 50 ml syringe they've given. And you can see that the tip has some needle which is like a butterfly needle. So with that you can guess. So this basically the needle is inserted in the subcutaneous space. So it is used for giving subcutaneous continuous infusion. Okay. So the tip of the infusion set will give you the clue. So that is a subcutaneous infusion needle. So in hematology oncology, which is the condition where this type of infusion is used? Any guesses? No answers?
Not. We don't have any answers.
Okay. Okay, fine. So this okay. So desferoxamine ion chelator, which is given either subcutaneously or intravenously. So IV or subcutaneous, it does not have oral preparation. So whenever they have a significant iron overload, we have to give a very high dose of desferoxamine, but we can't keep the child for continuously hospitalized also. So they can connect this infusion pump to their abdomen. They can connect it, and the what you see as a black belt is like a belt. It can be connected like a pouch, and the needle will be in the abdomen, and the child can sleep with that for 8 hours in a night. Daytime they'll attend school. Nighttime 8 hours they'll have the continuous infusion. So you can give more dose of desferoxamine as a slow infusion, which will not irritate them, and the ion chelation will also be better. So infusion pump is very well known, desferoxamine, and used in thalassemia. Okay. So this is the chemo port. So this is the chemo port hub. So you can see that there are two pointers on the tip. So that is, we have a triangular shape thing. So the triangle you fix and you pierce the diaphragm. So this is the chemo port, and the previous one that we have seen is the chemo port access needle, that is Huber needle. So I want someone to tell you, or someone to tell. So these two are bone marrow needles. That is very clear. So what is the difference between the first needle and the second needle? So one on the left, one on the right. So what is the difference? Anyone?
So first tunnel puncture with guard.
Okay, good.
We only have
Okay. Okay. So which is a good thinking. So basically that has a guard. It will it will control our depth of penetration. So that is the bone marrow aspiration needle with a guard. So for sternum, yes, it is a very good safety measure to use. So but that device we can use only to do the aspirate. We cannot do a refined biopsy with the needle that is given there. So the left one is used went only for aspiration, whereas the right one is the Jamshidi needle that we commonly use. Jamshidi 13 gauge by 9 centimeter, 10 centimeter, which we use in children. That can be used also to do a trifine biopsy. Okay. So whenever we are planning a trifine, so whenever a plan for a procedure is made for a child, so you ask whether it's only aspirate or biopsy. Whenever a biopsy is planned, we have to make sure the Jamshidi needle is there. Even for aspirate, you can use the Jamshidi needle, but biopsy means you should have the Jamshidi needle only. Okay. Okay. So what is this instrument? This is again related to thalassemia. This is like an infusion set, which is connected to the blood bag. And there is something in between through which the blood gets filtered and then goes to the patient. So what is that white pouch that is seen?
Someone has answered leukocyte filter.
Great answer. So leukocyte filter is the correct answer. So in thalassemia, whenever they are getting repeatedly transfused, not only in thalassemia, but any sickle cell anemia or anyone who's getting repeatedly transfused, so we need to reduce the load of WBCs from the blood product. We want to give PRBC, packed red cells, but the WBCs will also be contaminating the product. So we can't completely avoid that. So we need to reduce the load of WBC because that will reduce the risk of febrile reactions, that will reduce the risk of CMV, that will also reduce the risk of alloimmunization in the future, meaning they will not develop much antibodies immediately. So this is a WBC filter which is preferred to use in the children with a repeated transfusion requirement. Nowadays, the blood bank will do the WBC reduction before giving the blood bag itself. So they will separate the PRBC, they will centrifuge it further, and they'll further remove the WBCs in the product and then give us. So that leukofiltered product, if you ask for, they will give that. But the problem is if you do it in the blood bank by automated machines, the cost will increase by 1,200 rupees for a patient. But if you use this bedside filter, it will be less. So that is the importance. Okay. So what is this? If we see such a finding in the ward patients, immediately we should be worried about. So this is basically a ecchymosis.
There is answer. I'm not sure. PLTS,
Yeah,
platelets.
platelets.
Yeah.
Correct. Yeah. So platelets should be worried immediately. So platelets will present with skin and skin petechiae, mucosal petechiae, small ecchymotic patches. So that we should immediately look for the platelet count. Okay. So you must all be knowing this colored medicines. Can anyone want to try blue colored medicine in chemo? Blue colored chemotherapy, red colored chemotherapy, yellow. Any guesses? Red and yellow, you are definitely working every day in out. In fact, I told the answers earlier itself in the discussion.
Methoxytate and for yellow, and there are many answers for red doxorubicin and
Yes,
yellow is MTX. So there are,
yes.
yeah,
So
exactly.
yes, everyone has got that right. So red color is anthracycline. So rubicin, all ruby is red, whereas yellow is methotrexate. I told you the color coding is for the safety measure. Blue colored medicine is something called as mitoxantrone. Mitoxantrone or sometimes methylene blue also we use. But methylene blue is used in hematological condition. Mitoxantrone is the chemotherapy which is blue colored. Okay. So this you must be knowing better than me. Human waste disposal in which bag? In fact, I ask sisters every day where
So
to put an
yellow
input. So
yellow bag is the answer.
yeah, correct. Yellow bag is the right answer. Very good. So personal protective equipment includes which of the following? Which is the personal protective equipment here?
So mask is the answer
Yes, very
given
good.
by.
So this is very easy for them. Um, I'll. This is again an international patient safety goal related question. So right of a patient includes which of the following? Patient can shout in the hospital, leave the hospital without completion of formalities, right to second opinion, right to consume alcohol in the hospital. It's quite straightforward.
So most are answering C, and someone has answered
Yes.
B.
Okay, so B is not the right answer. So whatever it is, the formalities are very important. Second opinion is the right for every patient. We can't say I have tried so much for you, I have done so much, and I have given you correct plan. You cannot question. So second opinion for their mental satisfaction. It is very important for anyone to take. So second opinion, if they ask for an opinion, it's our duty to give them a proper summary and guide them where to take for a second opinion. Good. So it's a 3-year-old boy with thalassemia on regular transfusion. So what normally we do to check the iron status? We do it once in 3 months to check the iron status in the body. So which test we do?
Uh, D is the answer.
Yes,
Most
correct.
are
B is the
saying.
right answer. So in thalassemia, iron overload, ferritin is the reliable marker. And even in iron deficiency anemia diagnosis also, ferritin is a reliable marker because serum iron, it is a very volatile thing and it varies every minute to minute, every hour to hour. So it is a very, very unreliable marker. So that is why we use the serum ferritin, which is a marker of storage iron to check the iron status in the body. So to diagnose iron deficiency anemia also, we do serum ferritin. To diagnose the iron overload also, we do a serum ferritin level. Okay, good. So the next question. So we'll finish. So 9-year-old girl, BALF, is scheduled to receive Vincristin tomorrow. So and you see that you do the drug reconciliation always, write the drugs, what all they are taking. So these are the drugs taken by the patient. So which is the one you want to stop because the child is due for Vincristin?
So we have an answer, which is a B option, and also we have an answer for D option.
Okay, B and D.
Yeah.
Okay, both are not right. So it is answer is C. Okay. So
So
oriconazole is one drug. Has anyone answered that?
yes, now we have an answer A as well and C as well.
Okay, so C is the right answer. Oriconazole is the right answer. It's an anti-oriconazole, fluconazole, posaconazole. All these drugs have a significant interaction with vincristin. So if the patient receives the same dose of vincristin while they are on oriconazole, the toxicity of vincristin will go. The toxicity of vincristin will significantly increase. So it has to be either we have to stop the oriconazole for 2 days when giving vincristin, or we have to reduce the dose of vincristin while giving. So this is very important as a senior staff when you supervise the other drugs interaction is very, very important. Okay. Mother of a child on ALL chemotherapy, after admission, she reports that there is a vesicular rash in the trunk and fever for 1 day. So the mother is having the rash. Only. No, what should do now? The child is not having rash. Mother is having rash. The child is already in the ward since morning. Night only she's saying, I have this rash. So what should do? Any guesses?
So there is one answer that we should isolate.
Very good. So we have to isolate the mother, isolate the child also, obviously. And what else to be done? The second most important point. Because the mother is there for more than 6 hours in the ward. She would have been interacting with other patients also in the ward.
So we have answer observe and isolate. Dermat refer and
Okay.
PPE.
Okay. Yes, dermatology, yes, definitely we should get an opinion. But this, see, whenever the children are on chemotherapy, the complications of varicella can be very bad. So normal child varicella, we only isolate and care them at a separate place. That is more than enough. Children on chemotherapy, if they develop varicella, it can lead to a significant complication and it can lead to death. So we have to isolate this current patient, and that child has to be started on acyclovir prophylaxis. And all the other patients in the ward, whoever has received chemotherapy, are supposed to be started on acyclovir prophylaxis for a week. 1 week, we have to give them acyclovir prophylaxis. This is very, very important. And you need to report it immediately to your senior in charge, hospital administration, get them isolated, start the acyclovir within at least 12 hours of exposure known. Okay. Yeah. So which vacutainer is used to send the serum fibrinogen test? Serum fibrinogen or any clotting uh, factors assay.
So we have answer blue.
Correct. Blue or it is sorry, the answer here is wrong. It's a citrate container or blue
Citrate.
container, which is correct. Yeah.
So we have a citrate
So,
also in the
yes,
answer.
that's correct answer. That's a correct answer. What I have written here is wrong. That's for a different question. That's wrong. Yeah. So, what agent is used along with cyclophosphamide to reduce its side effects? Cyclophosphamides
So
reduce.
there
Yeah,
is answer Mesna, if I'm not wrong in the
correct,
pronunciation.
correct, correct, correct. Yeah, so mesna is the very right answer. Yes. So there are specific antidotes: cyclophosphamide, mesna, methotrexate. It is folinic acid, and we should have the mesna and folinic acid in hand before we connect the cyclophosphamide or methotrexate. And these are drugs, and even ifosfamide will need mesna to reduce the side effects. And we need to hydrate them very well, even 1.5 to 1.75 times hydration is needed to reduce the toxicity of all these chemotherapy. So I'll skip this. It's full form of CMV. You must be knowing it's cytomegalovirus. Um, yeah. So what chemotherapy among the following needs good accompanying hydration? I already told you methotrexate is the right answer. Methotrexate, we need a particular hydration with alkalinization. We add soda bicarb to the hydration so that the blood pH is always maintained above 7, so that urine pH is maintained above 7, so that the methotrexate does not stay in the body and keeps on getting excreted normally. And we cannot take lightly at all. Okay. So this must be the last question. So what is the price? What does price stand for in the care of hemophilia patients? Earlier, we called it as rice. So, hemophilia, when they present with a joint bleed or joint swelling, so this is the first aid measure that we need to do.
So
So, we
there
have
are
a mnemonic for that. Yeah,
answers A option.
that's correct. Very right. So, first is so price is the mnemonic for hemophilia patients. So, basically, protect the joint so you don't mobilize it further and you don't use that part which is bleeding further. Rest the joint. Give an ice compression immediately. Ice compression, when we say, we also don't stress it. And patients also say, I did 2 or 3 times. That is not enough. So ice compression has to be repeated every 2 hours. And compression bandage has to be put and limb has to be elevated. So that is the mnemonic for hemophilia. Okay. So we'll stop with this. I'll stop the screen share. Yeah, I can see 99 chats now. So that's great. Uh, So, any questions or any comments or anything from the audience? So, because you've covered most of the topics related to hemato-oncology, even so, we thought we'll have a interactive session. It'll be more good if you could all unmute yourself and speak from the next session, because that is when when you speak out, you know how much we don't know. All that will be better. So we'll try to have more interactive session. The next month, because we have a national uh, conference, FOCON, we won't have the class next month. So we'll have resume the class in December. Okay. There are no questions, comments, then we can close the session.
So thank you so much, ma'am. And I have shared a feedback link in the chat box. I request all the participants to just fill the feedback for this particular session. And if we have no questions, then we can end this session. So there is something in the chat box. Dr. Dharini, if you can check the chat box.
Yeah, sorry. Yeah, sorry. I was actually speaking with muting. So the Clostridium difficile is managed with metronidazole or oral vancomycin. Okay. The basic thing is it is a concept that it's an antibiotic induced colitis, but most of the time we will not be able to stop the broad spectrum antibiotics, but we give them IV metronidazole or oral vancomycin. Oral metronidazole is also accepted, but with colitis, they may have more gastritis and irritation. So IV metronidazole will also help in Clostridium difficile management. It has to be given for at least 10 to 14 days. Oral vancomycin is the next drug. If IV metronidazole alone is not helping, you can add the oral vancomycin and you can use both the drugs together also. So the total duration is 10 to 14 days you need to give. Okay. Thank you. Thank you everyone for the active participation. We'll close the session.
Okay, thank you so much.
Thank you.